So we will start with Sengstaken Blakimore tube. So this was a conventional tube which was introduced for the purpose of controlling esophageal varices bleed. It was actually used in the pre-endoscopic era, or when the endoscopy was not much used. So for controlling uncontrolled esophageal varices bleed, or in patients in whom TIPS is awaited after a failed esophageal variceal therapy on them, Sengstaken Blakimore tube can be used. But the major complication is that it will result in too much of aspiration, and since the pressure traction is being applied, tamponade effect is there on the esophagus or the lower part of the OG junction. There can be pressure ulcers in the esophagus or in the OG. Esophageal perforation, mediastinitis, they are all dreaded complication. So if you see the parts of a Sengstaken Blakimore tube, what you see is that this is a latex made tube usually, or silicone tubes are also available. Diameter is around 6 to 7 mm, that is approximately about our just more than that of our pediatric endoscope. Or and this tube, the important points you should remember is that this tube, this is the end which goes into the gastric part, and uh, this is the end which goes into the gastric lumen, and this balloon what you see is what is present inside the stomach, and this balloon what you see will be in the esophagus. And in the outside of this tube you will see three lumens, or three channels will be there, and one will be for esophageal balloon dilatation, other one will be for gastric balloon dilatation, and center one will be for aspiration of the gastric contents. So important thing is that the gastric balloon is inflated using 200 to 250 ml of air. It is not water, it is air. And esophageal balloon should achieve a pressure of 35 to 45 ppi pressure should be achieved. So this is another variety that is newly available, that is a silicone. What we knew is the lactase based one. This is silicone based Sengstaken Blakimore tube. Steps of insertion is, see, to insert this, the airway should be protected. So the patient should be intubated, and the tube can be inserted via nose or mouth. While inserting through the nose, there is challenges like perforation can be there. This tube is more of rigid type one, unlike what you feel like it is more of rigid like one. So there can be damages to the nasal cavity. So what you do is we intubate the patient and insert it via nose or mouth. If you're using through the mouth, by using a laryngoscope, visualize the oropharynx, visualize the esophageal opening, use a McGill's forceps and insert into the esophagus and then push it down. And once it reaches the stomach, you either aspirate the content and see. Aspiration might not be always helpful, because sometimes even if it is in the esophagus also, aspiration may yield some amount of blood. So push it inside and confirm the position by using a stethoscope or an X-ray. X-ray is not practically always possible. And then dilate the gastric balloon. We should dilate using 200 to 250 ml of air. So the gastric balloon, when dilated, you just pull it back and give a adequate traction, not too much, not too less, adequate traction to just prevent it from coming out, and giving a tamponade over the lower esophageal varices, and fix it outside the patient's body, like using a pulley system, which is attached to the bed of the patient, by giving a weight of around 500 to 1 kilogram, and fix it. After 15 minutes to 30 minutes, just reassess the patient's bleeding is controlled or not. If bleeding is not controlled, then in that cases esophageal balloon can be inflated. And esophageal balloon inflation is not based on just fixed volume, but rather it's like the esophageal balloon channel should be connected to a manometer, and the pressure should be measured, like it should reach around 350 to 400 pressure should be achieved. It is not based on volume. So why air is used and not saline or water is used is that air will be more compliant, and it will prevent the, like if you use water, perforation of the or rupture of the balloon is very high, so the rupture of the balloon can be prevented, and sudden expansion can be achieved if you use air instead of using balloon. And even if the balloon ruptures or bursts, if it is water, it will cause aspiration. Air do not have that risk of aspiration. Then especially in esophageal balloon, if we have air, adequate pressure building can be achieved with air, with adequate distension of the balloon can be achieved. Therefore air is not used, it is not water. And the challenge is that as of now you would have understood it's a large tube. Insertion is very difficult. If you're going to insert it through nose, it will cause much of injury to the nasal cavity and perforation. Insertion through mouth is also very challenging, as I described through you. This is a modified version of Sengstaken Blakimore tube. That is, this tube is known as Minnesota tube. Only difference is that it is similar to that of SB tube, but it has four channels outside. One additional channel it has, which will help to aspirate the content above the esophageal balloon. So if this is the esophageal balloon, here there will be some openings which will help to aspirate the esophageal content above. So aspiration risk, overall aspiration risk for the patient will be less in Minnesota tube. Then we have a Linden natural tube. This angle is not used now. Basically, this was proposed for gastric varices. So this tube was actually initially brought for, this is single balloon. Only a large gastric balloon is around 500 ml volume. So this tube was actually initially brought for nasogastric decompression of patients with small bowel obstruction. But currently, these tubes and are obsolete only. But just for your exam's sake, you should remember about Linden natural tube. This Linden natural tube can be used for gastric varices also, single balloon. So this is the image which compares all the three balloons. This is a Linden natural tube which has a single balloon, around 500 ml of air should be used, and for gastric varices. So since it is very large, it can compress the gastric IGV. Gastric varices can be compressed. This is the classical Sengstaken Blakimore tube, which is having three channels or opening. One is for the gastric balloon, other for the esophageal balloon. The middle one will be for aspirating the gastric content. And this is Minnesota tube, the similar to that of Sengstaken Blakimore tube. We have an additional channel for aspirating the content above the esophagus. Thank you. Hope it helps you.